This is Chapter 6, Part B, on bones and skeletal tissues. So formation of the bony skeleton begins around the second month of development. This process is called ossification or osteogenesis. So whenever you see ossi or osteo, we're talking about bone tissue. So genesis being the beginning or formation of bone tissue. So once the skeleton is fully formed, it will continue to grow until early adulthood. And then bone remodeling and repair can occur throughout life. So bone remodeling and repair are lifelong. So no matter how old you are when you break a bone, it will still eventually heal. So up until this process of ossification or osteogenesis begins, the skeleton is made out of hyaline cartilage, kind of as that template or scaffolding for the rest of the skeleton. So bones can develop in one of two ways, depending on what type of bone we're trying to make. So most bones in the skeleton, with the exception of like the skull bones and some flat bones in the body, will be formed by endochondral ossification. So this involves bone tissue replacing hyaline cartilage tissue in that kind of template skeleton. So endo meaning inside and chondro meaning cartilage. So bone tissue is going to form from inside of cartilage. The skull bones and some other flat bones like the clavicle or the collarbone form via intramembranous ossification. So instead of forming from that cartilage template, it's going to form within a fibrous membrane, right? So intra meaning inside, so membranous, so inside the membrane we form the bone tissue. So essentially all bones inferior to the skull will be formed via this endochondral ossification. So we said this begins around the second month of development in utero. So it's going to form the bone tissue from that hyaline cartilage model. Right? So from inside the cartilage, we will form bone tissue. This process begins at what's called the primary ossification center, so being our first bone-forming center in this hyaline cartilage model. Blood vessels will also start to infiltrate the perichondrium or the outer layer of the hyaline cartilage skeleton and convert it into the periosteum or the outer layer of bone tissue. 5 main steps in endochondral ossification. So step 1, we have the bone collar forms around the diaphysis or the central shaft of the cartilage model. The cartilage will then start to calcify within this ossification center and start to form the marrow cavities. Once we have the cavity formed, step 3, the periosteal bud will invade this cavity and ultimately lead to the formation of our spongy bone tissue. This periosteal bud is made up of mainly blood vessels, nerves, some red marrow, and some other bone cells. So as the bones continue to develop, the diaphysis will elongate and our medullary cavity will start to form. Also happening in this stage, we have our secondary ossification centers start to appear. So remember, we started the process at the primary ossification center, and then we're starting it again at our secondary ossification center. And then finally, step 5, the epiphyses, or the ends of the bones, will ossify. So at the end of the process, the only hyaline cartilage that's going to remain in the bones is found in the epiphyseal plates in between the diaphysis and the epiphysis, as well as the articular cartilage at the sites of joint attachments. So the reason we need this secondary ossification center is, remember we said bones grow from this epiphyseal plate, from this cartilage. So if we did not have the secondary ossification center and we just continued the process of ossification going from this primary ossification center, we started in the middle, we went all the way out to the ends, then it would just be solid bone. We wouldn't have any cartilage left to add new bone tissue and increase the size of our bones in the future. Right. Again, so just to summarize endochondral ossification, step 1, we have our bone collar forming around the diaphysis and our primary ossification center in the center of the diaphysis of the hyaline cartilage skeletal model. So the cartilage cells in that ossification center will start to calcify and develop arcavities, which allow the invasion of the periosteal bud, so these blood vessels, nerves, marrow, and other blood or bone cells. So step 4, the diaphysis continues to elongate, and our secondary ossification center appears in the epiphyses. So then step 5, the end result, we have our fully ossified bone, where the only hyaline cartilage remaining is found in the epiphyseal plate and the articular cartilage. Intramembranous ossification is how we form the flat bones of the skull and the collarbones or the clavicles. So this process begins with fibrous connective tissue membranes formed by mesenchymal cells. So again, intramembranous ossification is bone formation within a membrane. So there's 4 major steps involved in intramembranous ossification. Step 1, so just like in endochondral ossification, it's going to begin with an ossification center. So with endochondral, we had that primary ossification center in the diaphysis. In intramembranous, we have the ossification center within that tissue membrane. So our mesenchymal cells will cluster and form osteoblasts. Remember, osteoblasts were the bone-forming cells that are going to secrete the matrix. So step 2, these new osteoblasts will secrete our bone matrix or osteoid within the fibrous membrane and then calcify. So it's similar to endochondral ossification, where we kind of start in the center and then the bone tissue or the process of ossification slowly spreads outward through the rest of the bone. Step 3 is when we start to form the woven bone and the periosteum. So the woven bone is basically a network of trabeculae that's going to kind of interweave between all of the blood vessels. Step 4, now lamellar bone or compact bone is going to replace some of that woven bone. So remember, with our flat bone structure, we have the spongy bone kind of sandwiched in between the 2 layers of compact bone. So the remaining trabeculae will then fill with that red marrow where all blood cells will be formed. So once the skeleton has been developed, it will continue to grow postnatally until adulthood. So long bones, so like the bones in your arms and legs, can grow lengthwise by interstitial or longitudinal growth. They can also increase in thickness and width via appositional growth. So normally bones will stop growing at the end of adolescence during adulthood. So the growth plate, that plate of hyaline cartilage, that epiphyseal plate that we left behind when we developed the bones, will eventually completely calcify and the bone growth will stop. However, bone remodeling and repair can occur throughout life. So if you break a bone as an adult, it will grow and repair itself. So that interstitial growth or growth in length requires the presence of that epiphyseal cartilage in the epiphyseal plate. So the epiphyseal plate maintains a relatively constant thickness. We just kind of slide it up the length of the bone as we add bone beneath. So the rate of the cartilage growth on one side of the plate will be balanced by replacement by bone on the other side of the plate. So we're essentially just kind of shifting the plate outward. So there's 5 zones in the epiphyseal plate. The resting zone or the quiescent zone is where the cartilage is relatively inactive. It's just pretty much regular everyday cartilage. It's not really doing anything. However, below that resting zone is where we start to see some activity occur with the chondrocytes or the cartilage cells. So the first zone is the zone of proliferation or growth. So the cells will just start to grow and divide. Below that is the hypertrophic zone. So the cells will start to enlarge and increase in size, followed by the zone of calcification. So now they're starting to calcify and harden. And finally, the ossification or the osteogenic zone, where we have new bone cell formation. So the end result is the cartilage is replaced by the bone, and the overall length of the bone increases. Again, so the proliferation zone, so proliferating means dividing and growing. So we have rapidly dividing cartilage cells. So just like with the epidermis, older cells will be pushed toward the surface or moved upward. So as new cells are formed, they're going to be pushed upward and push that epiphysis away from the diaphysis, resulting in a lengthening of the bone. The hypertrophic zone is where these older chondrocytes closer to the diaphysis will start to get larger and start to break down. So as they enlarge and break down, they're going to form these interconnecting spaces that will contribute to the later bone structure. The calcification zone is where the cartilage matrix will begin to calcify. So the cartilage cells are dying and becoming calcified and hardened. The ossification zone is where we have new bone being formed. So when the cartilage cells die, they leave these long spicules or little spikes of calcified cartilage at this epiphysis-diaphysis junction. So those kind of skeletons of our dead cartilage cells will then be covered and replaced with new bone cells by the osteoblasts. So you can kind of compare the different appearances of the different zones. So here's our resting zone, again, just normal cartilage. Proliferation, the number of cells are starting to increase, get a little more densely packed in there. Hypertrophic zone, the cells are enlarging and starting to break down, and then calcification zone followed by ossification. So near the end of adolescence, these chondroblasts, or the cartilage-forming cells, will divide less often, so the growth will slow down. Ultimately, the epiphyseal plate will thin and be entirely replaced with bone. So this is called the epiphyseal plate closure. So once we reach adulthood, the epiphyses and the diaphyses of our long bones will fuse together. So this will mark the end of all long bone growth. So this is showing open growth plates. You can still see that line of cartilage, kind of a dark line, as opposed to a closed growth plate. So there's no more cartilage there. It's all been ossified into bone, and sometimes referred to as a scar. So it's just a pale white line where that cartilage used to be. So this plate closure happens around adulthood, so around 18 years of age in females, 21 years of age in males. Bones can also grow in width or thickness. So as they grow in length, they're also going to need to grow in width to maintain their proportions. So this type of growth can occur throughout our life. Bones thicken in response to increased stress from muscle activity or added weight. So when bones grow in thickness, the osteoblasts beneath the periosteum on the outer layer of the bone will secrete new bone matrix, while simultaneously the osteoclasts on the endosteal surface will remove and break down the bone tissue. So it's all about maintaining that proportion. So if we were just to add layers of bone on the outside of this, we would have a really thick bone with a narrow medullary cavity. So we want our medullary cavity to have relative proportion to the thickness of the bone. So the end result is we have a thicker, stronger bone, but it's not too heavy. So as our bones grow, they also will undergo remodeling. So again, bone shape is all kind of a response to the stresses that we put on the bone. So added weight or muscle stress will kind of shape the bones to reduce the amount of weight and force on the bones. So showing here before growth and remodeling, here's our original size of the bone. So as the bone grows in length from the epiphyseal plate, so we're growing in length, we're also going to have to grow in thickness and width. So we add some bone growth here to the diaphysis, and we resorb or break down some bone here to maintain that shape and proportion. So here would be our new outline of our bone after growth and remodeling. So hormones play an important role in bone growth as well. Growth hormone is probably the most important in stimulating that epiphyseal plate during childhood and adolescence. Thyroid hormone also plays a role by modulating the activity of growth hormone and helping to ensure we have proper proportions. So thyroid hormone is kind of the major metabolic hormone in the body. So metabolism is linked to our growth. Sex hormones such as testosterone in males, estrogen in females during puberty can also promote adolescent growth spurts and puberty. They also can trigger the end of growth by inducing the closure of the epiphyseal plate. So just like everything in the body, we want everything to be within those homeostatic ranges, maintain that balance. So any excess or deficits of these hormones can cause an abnormal skeletal growth. So if someone has a hyposecretion of growth hormone, meaning they don't produce enough, that could lead to a pituitary dwarfism, as opposed to a hypersecretion, so we have too much growth hormone, can lead to gigantism. Two other hormones that are important in bone growth and homeostasis is calcitonin and parathyroid hormone. So these hormones regulate our calcium metabolism, which is important for our bone health. So these two hormones work antagonistically, so they're going to be opposite one another. So they have the opposite effect, but they can maintain our calcium no matter if we have too much blood calcium or if we don't have enough. So say we have rising blood calcium levels. So calcium is getting too high in the blood. We need to lower our blood calcium. So the thyroid gland will release calcitonin, which will stimulate calcium salt deposit in the bone. So it'll stimulate the bones to take up the calcium and to deposit more bone tissue. Right? So we'll return to homeostasis. Vice versa, if we don't have enough calcium, then the parathyroid glands will release parathyroid hormone. So this hormone stimulates osteoclasts, or those breakdown cells, to break down the bone tissue and free up and liberate some of that calcium for the blood. Bone remodeling occurs throughout our lifespan. So about 5 to 10% of your bone mass is recycled every year. Your compact bone is replaced completely every 10 years. So about every 10 years or so, you're an entirely new person. So bone remodeling consists of both bone deposition or bone formation and bone resorption or breakdown. It's going to occur at those endosteal surfaces. So osteoblasts and osteoclasts respond to different signals from hormones or stress-sensing bone cells. So the osteoclasts will break down old bone while our osteoblasts form our new bone layers. Remodeling occurs continuously but is regulated by some control loops. Hormonal controls of blood calcium, so parathyroid hormone and calcitonin, right, to maintain blood calcium levels. So parathyroid hormone raises blood calcium, calcitonin lowers blood calcium. Remodeling also occurs in response to mechanical stress, so increased weight or compressive forces on the bone can change their shape. So in this example, this bone is slightly bowed a little bit. It's not completely straight. So there's more force being exerted on the medial surface or the inside of the bone. So the osteoblasts will add new bone tissue to this side, to this curve, and break down bone tissue from the outer curve. So we get a more straight and narrow bone shape. So now, the result, the weight is more evenly distributed along the bone. So bone repair can occur throughout life. Fractures are when the bone has been broken. So most fractures result from some type of trauma in young individuals. In older individuals, it can result from just weakness of bone due to bone loss and thinning. So there's three main ways that we classify fractures or bone breaks. So we can classify them based on the position of the bone ends after the fracture. So are the ends still in their normal position, kind of in the right place, normal alignment, or are they out of their normal alignment? So is the bone no longer straight? So a non-displaced means that the ends are where they should be. A displaced means that the ends have been pulled out of their normal alignment. We can also classify fractures based on the completeness of the break. So if it's complete, it's broken entirely all the way through clear across. An incomplete break is just where it's cracked a little bit, but it's not completely broken or detached. We can also classify fractures based on whether or not the bone penetrates the skin. So an open or compound fracture, the bone shards, the jagged broken bone ends have pierced through the skin, whereas a closed or simple fracture, the skin is not penetrated or affected. So some common types of bone fractures include a comminuted fracture. So this is where the bone essentially shatters. So the bone fragments into 3 or more pieces. This type of fracture is more common in elderly people whose bones are just naturally more brittle and easier to kind of crumble. Compression fractures involve the bone just being crushed, undergoing extreme compressive forces. So this is also more common in older people who are more prone to osteoporosis, right, and these porous bones. Spiral fractures are where the bone essentially twists and breaks in a spiral pattern. So these are common in sports injuries. Epiphyseal fractures occur when the diaphysis separates from the epiphysis along that epiphyseal plate. So again, this is more common in younger individuals that still have their epiphyseal plate. So that line of cartilage is actually a weak point that can become disconnected and broken. Depressed fractures are commonly found in the skull, where the broken bone portion is just pressed inward or has a depression in the bone surface. Green stick fractures are incomplete breaks, common in children whose bones are still relatively kind of flexible than an adult. So it's named a green stick fracture because it looks a lot like a green twig. So if you try to snap a green twig, it's not going to snap cleanly. It's just going to kind of bend and shard. So these bones break in a similar fashion. Fracture treatment involves reduction and realignment of the bone ends. So when the bone heals, we want it to heal properly. So we want those ends to be lined up appropriately. With a closed reduction, the doctor can simply just kind of physically manipulate the bones back into the correct position. An open reduction is a little bit more intense, where we have to involve the use of surgical pins or wires outside the bone to ensure a correct position and secure the ends together. Once the broken bone ends have been realigned, then the bone will be immobilized by a cast or some type of traction device until it's fully healed. So how long it takes for a bone to heal depends on where in the body, the age of the patient, various hormonal, nutritional differences, and severity of the break. There's 4 major stages of fracture repair. So step 1 is hematoma formation. So we basically just have a blood clot form, followed by a fibrocartilaginous callus formation. So we have some cartilage to form kind of a temporary scaffolding, followed by a bony callus formation. So now bone tissue will replace the cartilage tissue and begin the healing process. And then finally followed up with bone remodeling. So the bone will make those minor adjustments and tweaks in its shape in response to weight and compressive forces. So hematoma is a technical term for a blood clot. So bones are very vascular. Remember we talked about the structure of osteons. They have all of those blood vessels that run through them through the central canals, and then we have the communicating canals that run perpendicular all throughout the bone tissue. So when the bone breaks, a lot of blood will be released into that tissue space. So initially the site will be very swollen and painful and inflamed. Once we've stopped the bleeding, capillaries will start to grow into that hematoma. Phagocytes, or some immune system cells, will come in and clear up the cellular debris, so all the dead, dying cells, blood cells, bone cells, damaged and injured tissues, set the stage for repair. Fibroblasts will start to secrete collagen fibers to connect the broken bone ends and form kind of this temporary attachment. Osteogenic cells will begin the process of reconstructing the bone. So again, this is called the fibrocartilaginous callus. So kind of like a callus on your hand, right? So this is a callus on the bone to protect it until it heals. So within a week or so, that fibrocartilaginous callus will be replaced by bone tissue. So those trabeculae will start to reappear, right? New bone will be formed. So this process will continue for a couple of months until we have a firm, solid union between the broken bone ends. So once the bone has been repaired, it will continue to remodel for several months after healing. So ultimately, the final structure of the bone will resemble the original structure before the fracture. So it's going to respond to those same mechanical stressors. Right, so summing up fracture repair, right, so hematoma formation followed by fibrocartilaginous callus formation, or kind of temporary scaffolding, right, or our template for where we're going to deposit new bone. Right, so then we replace that fibrocartilaginous callus with the bony callus. So now the bone is healed and it will continue to remodel, right, and adjust to compressive forces. Various types of bone disorders all have the same underlying cause. So there's some type of imbalance between bone deposition and bone breakdown. The three major types of bone diseases include osteomalacia and rickets, osteoporosis, and Paget's disease. Osteomalacia and rickets are both diseases caused by vitamin D deficiency or insufficient dietary calcium. So rickets is just osteomalacia in children. So it's characterized by the bowed legs and maybe some other bone deformities. But ultimately, the bones are poorly mineralized. So normal bone, you have kind of this dense structure. Osteomalacia, it's much more porous. So not as much osteoid is calcified. What results in softer, more weak bones that have pain upon bearing weight. So this is why the children's bones, since they're still growing, their legs will start to bow under their growing weight. Osteoporosis is a group of diseases in which bone resorption exceeds bone deposition. So the matrix will remain normal, but the overall bone mass will decline. So the most susceptible areas of the body are the spongy bone in the spine and the neck and the femur. So this is why elderly people are more prone to having that humpback appearance and hip fractures. So when an elderly person falls and breaks their hip, they're not actually breaking their actual pelvis. What's breaking is the neck of their femur. So this is considered a weak point. So with osteoporosis, the bone is already kind of brittle and not as thick. So during a fall, there's lots of extra force, compressive forces on this relatively narrow neck region of the femur that's supporting basically all of the body weight. So it's easy to break at that point. Some risk factors for osteoporosis. So it's most common in postmenopausal women. So because estrogen plays a role in bone density and calcium absorption, after menopause, women stop producing as much estrogen, so they stop absorbing as much calcium. So as a result, their bone density is going to decrease. Men are less prone to osteoporosis because of testosterone is going to keep their calcium metabolism healthy. So preventing and treating osteoporosis, traditional treatments include weight-bearing exercises. So remember we said that bones will adapt to the stresses you put them under. So if bones are exposed to more compressive forces, more weights, they will try to remodel and adjust and adapt to that added weight. So weight will be more evenly distributed and easily carried. Also treated with calcium and vitamin D supplements or some drugs that inhibit osteoclasts. Remember, osteoclasts are the cells that break down bone tissue. So if we don't want to break down any more bone tissue, we can try to slow down that process. Paget's disease is kind of the opposite of osteomalacia and osteoporosis. So the other two, we had kind of poorly mineralized bone or not enough bone deposition. Paget's disease is where you have excessive and kind of random bone deposition. So the bones grow fast and develop poorly. So they're not as mineralized as normal healthy bone because they grow at such a rapid rate. So they're kind of half-hearted formed bone tissue. So this usually occurs in the spine, pelvis, femur, and skull. So it can cause bowing or deformation of the bones. So it rarely occurs before age 40, but what's scary is that the cause is still unknown. It's theorized that it could possibly be triggered by a virus or a genetic component, but we still don't know. So treatment for Paget's disease includes calcitonin and some biphosphonates. Calcitonin was the hormone that raises blood calcium. So it does this by breaking down the bone tissue. So if their problem is they're making too much bone tissue, we can supplement with calcitonin to help break down some of that excess